Hey guys, Don here. Welcome to the $1,000,000 Minute. This is where I kind of go through each day, kind of the things that help get to the $1,000,000 mark here in private practice. Might give you some inspiration and also things that I'm kind of struggling with. What I found recently, as I've been going through and doing a lot less lower level visits and kind of more patient visits, I'm finding that my time is, it's obvious, but my time is even used up even more. So I have to be much more efficient. And I am kind of extending my hours a little bit, and I'm not really liking that. I am feeling more profitable, but it takes a little bit more work. So I really notice as I look at the numbers have changed from like 600 to 800 now. I think this year at end of October I just went past the $1,000,000 in actual collections. And as I'm doing this and I'm consciously seeing less low value patients, just not having them come back unless there's issues, and trying to focus more on higher, it tends to be a little bit more detailed. So just something to think about as you're doing that, and that's where I think the scribe really helps me out to do that. Okay, so patients here, there was a Lamisil follow-up, which I gave them after the Lamisil follow-up is what I do, is I have them use a topical cream afterwards, like a ketoconazole for that. There's also a patient that we did EPAT. He has a fifth med head, kind of like bursitis metatarsalgia, and he had a surgical shoe that he was wearing, and we added a Pegacyst, one of those liners that we typically do for ulcers, but to offload that area. And he's going to be doing the shockwave and amnio at the next visit. So amnio will be the next visit. Another new patient that got my kind of plantar fasciitis number 1 with a Pelto special. That's the typical thing I do for most of my first visits, which was with meloxicam and a level 4 visit and a 3-week follow-up. There's a patient with a Lamisil booster, which you've heard me before, so the first round is 90 days. The second round I have a booster dose, which is a little bit less intense. Same thing for the next patient after that as well. And those ones, the Lamisil boosters, I'm not seeing them back. So this one and the other one, they're higher level visits because of the prescription management, but then I'm not seeing them back unless there's an issue. Another new patient that had kind of metatarsalgia, and did an orthotic for this patient, and I'm going to see them back in 3 weeks. And so that was an orthotic. So that was a good patient, because the first visit doing an orthotic, I usually introduce the topic the first visit, then usually the second visit is when I do the orthotics. Just so you know, in my practice, I don't have any over-the-counter. The reason I don't have any is people can get them online, and I just find if I only have one thing to offer, it just simplifies things, because I want to focus on the custom ones. Patient came in for ingrown toenail. I did an Onifix on them. I don't do tons of Onifix, but some patients are coming and asking for them if they've had them before. Another patient that came back with kind of some ankle pain, some posterior tibial tendon dysfunction, and I'm going to check on the AFO for them, and then they're going to come back. They're going to try the other things, the resting, icing, anti-inflammatories, things like that. Another patient that came in for a shockwave. Another patient that came in for a plantar fasciitis, and this patient opted for cortisone. This is cortisone number 2 in the fascia. They've already done 3 shockwaves in the past. They were a little frustrated. They didn't see much improvement, but they have a really thick fascia. So they didn't want to do shockwave. I still think that would be the better option for them, but they wanted the cortisone, so we did that. Just going to come back as needed. So I tend to find I tend to recommend certain things for patients, and then if they don't take the recommendations, I tend not to see them back as much. It's just a little bit easier if they take the recommendations, because I think certain recommendations I have work better than others. And sometimes the patients prefer to do what they want to do, which is a struggle. There's a patient as well, EPAT number 3 for the neuroma. I don't do a lot of EPAT or shockwave for the neuroma. I tend to more focus on the focused one with a lower intensity, and I'm going to give it more time. So instead of seeing them back at 6 weeks, I'm doubling that to 12 weeks, because it takes longer for, I think, the nerve to respond for that. And then there's another new patient that had a cortisone injection. Had pain kind of like to the base of the first and second metatarsal regions at the base, so I did an injection there. I also had a porokeratoma, so I did lesion destruction on the second med head, and then they'll just come back as needed. That was the morning. Afternoon, patient had bad TN, joint arthritis, got a cortisone, felt a little bit better. Talked to them, and I'm going to check about doing a meso, M-E-Z-Z-O brace, which is like just a midfoot kind of brace to reduce movement. And I'll call them. Another patient with a fungal nail, pretty easy, nail sample. And actually, this patient was just an older patient, so we're not really doing anything for this patient. A patient, kind of a struggle patient, came in for an orthotic adjustment. This is kind of a struggle. Orthotic adjustment sometimes can be a challenge, and it's kind of a challenging patient in general, but thankfully my lab can get new ones. But I spent quite a bit of time with her. That got me a little bit behind. Another patient with an onifix, another patient that had an outgrowth. This is a patient that was seen by another doctor for the same brand of orthotics, but then they closed shop. So I kind of, we're going to see them. Now, this patient I'd seen the mother for a while doing shockwave and things like that, and she brought in her son, and I'm not sure why, but they asked to waive the copay. This doesn't happen to me too often, but I'm usually kind of nice, so maybe this has happened, I don't know, once, or maybe they do it without telling me, but this time they actually asked, and I said, yeah, just waive the copay. Just trying to be nice because I saw the mom quite a bit. So those are some kind of judgment calls that we make. Another patient that came in that had a foreign body previously, and I did an ultrasound to remove a little bit of glass. Now I think this was a 3-week follow-up. They had a really big callus, like a deep porokeratoma, and so I kind of treated that kind of went in where the cut was. So I treated that with lesion destruction, and I did an ultrasound just to make sure there was nothing else in there, no other foreign body, and then no follow-up for them. My MVP patient of the day was a patient with a tibant tendonitis on the dorsal medial foot, and did shockwave number 2, and I had to do the cobalt tip, which is a little bit lighter because it's kind of intense in that area because of the bone, and then we did an amniotic injection, and then she wore her boot. So this was kind of the MVP patient of the day. And then another patient came in for Achilles tendonitis, got my Pelto special, which basically is meloxicam, night splint, foam rolling, and morning stretch. And they're going to do a 3-week follow-up, and we'll do an ultrasound. And then the other patient was a patient that came in for a plantar fasciitis follow-up. Really wanted to think about options. She was one that I gave some instruction. I always send out something called Patient Education Genius, which is basically a link to a blog post that really goes in detail about the condition they have. But I find some patients aren't looking at those, so I'm trying to think of a better way of doing that, getting them to look at that stuff. Because I sent it to her again, and she was sad she didn't look at it, but I think a lot of patients just ignore things. So I'm trying to think of a better way I can actually have them look at things. I send it to them, I text it to them, maybe email is better, but I haven't figured out a great way. If you have a great way, let me know. But I feel like if she would have looked at that, she would have known like what's next. So she's going to look now at cortisone or shockwave or things like that. And then the last patient of the day was a patient with a fracture follow-up, but she also had some plantar fasciitis. So we did an ultrasound bilaterally, showed kind of thickness of the fascia just on one side. Patient's going to go to PT, and then possibly after that, shockwave. The challenge is he's in a walking boot for the fracture, and now he has plantar fasciitis, and so that's why I'm doing kind of the shockwave. The physical therapy first, and then shockwave after. Anyway, that's the day, and hope this is beneficial. And let me know if you have any thoughts or ideas or anything that you would have done differently. Okay, thanks.